welcome everyone for a wonderful evening that we've got planned for you called Beyond Symptom Cycling. We'll talk about an welcome everyone for a fascinating evening we will have on called Beyond Symptom Cycling. This is a new era of targeted care in non-advanced systemic mastocytosis. Now we've got some technological updates. We're offering this as an interactive experience and a live event. So for those of you joining us through the internet, as well as you live, please go ahead and scan the QR code because that's going to be the way that you can view slides, access today's content, and ask your questions. So put that on your personal device. You've got, for those who are here, you've got the Wi-Fi code as well. And as we move along, I'd like to present our faculty tonight, our experts, starting with Dr. Tracy George, who's a professor of pathology at Spencer Fox Eccles School of Medicine at the University of Utah in Salt Lake. Dr. Lindsay Ryan, associate professor of medicine at Duke University Health System in Durham, North Carolina. And Dr. Nathan Boggs, allergy division director, Department of Medicine and School of Medicine at the Uniformed Services University in Bethesda, Maryland. And I'm your host, Rafi Tashtian. I'm associate professor of medicine and pediatrics at the David Geffen School of Medicine at UCLA. Now for the agenda tonight, the opening spotlight will be Beyond Stability and the KIT-driven burden in non-advanced systemic mastocytosis with Dr. George, followed by breaking developments in KIT inhibition, evidence shaping the future of systemic mastocytosis care with Dr. Lindsay Ryan, and reframing treatment control, what stability should mean in modern SM care, and that's with Dr. Nathan Boggs. Clinical pearls and takeaways will be done in a team fashion, and you can ask the experts. This is your time to ask those questions and make it live. But before we go on, we've got a news flash from our patient Bree, who will report from afar on her symptoms.
So you asked about the symptoms that I experienced and the burden of those symptoms on my daily life. And you know, it definitely takes me a moment to reflect back on that because it's been a bit of a journey and it's been different over time, and it's something that's definitely worsened over time. When I was young, it was your typical nasal respiratory symptoms, those sorts of things. You know, sometimes a lot of kind of mucus clearing. But as I really entered into my 30s, there was a lot more GI upset. Some of that urgency would be less predictable and unknown cause. It was not always easy to tie it to one particular thing, why this may be occurring. The other thing that really started to weigh on me was that unknowing what the cause was and getting to the point of wanting to do like a strict elimination diet to really try to identify what is causing these things to occur. There was near constant headaches. I said to a colleague at one point in time that I have a headache every day of my life. And in my mind, that was just something that people experienced. And kind of until you talk to other people, you don't realize that that's always the case. Again, you know, as kind of going through the early treatment journey, the bone pain became very, very severe, and it was nightly, and it caused, I would say, excessive use of diphenhydramine. It seems to be the only thing that would relieve that pain. And no one likes to feel that fatigued all the time. But it was what you do to survive. And I think that's also been part of what has contributed to the excessive fatigue that I've experienced at different points in time, or moments where I really did struggle to find my words and cognitive issues that were tough. And I think we don't always realize how that also impacts the people around us. It affects your intimate relationships when you don't feel up to spending time together or going out and enjoying things, or even having date nights like you used to, or spending time playing with your kids. I think, you do all these things to cope and to move throughout your day, and it does have a big impact on your life overall.
And so now, leading the next section is Beyond Stability, the kit-driven burden in non-advanced systemic mastocytosis. Dr. George.
Thanks, Rafi. It's nice to join you all this evening. So let's talk about systemic mastocytosis. So this is a very rare disease. It's characterized by the accumulation of clonal mast cells. And so one way to think about it is there's skin-only disease, that's cutaneous mastocytosis. That primarily occurs in the pediatric population with skin-only disease, often macules and papules that are kind of red-brown. And those then will disappear by the time those children approach puberty. But today we're going to be talking about systemic mastocytosis. And that's defined as extracutaneous organ involvement with or without skin involvement. And this is disease primarily of adults. The prevalence of systemic mastocytosis is estimated at approximately 1 to 5,000 to 1 to 10,000 individuals in the United States. Most patients with systemic mastocytosis have non-advanced disease, and a small number have what's called advanced systemic mastocytosis, and this is characterized by organ damage and decreased survival. So the KIT D816V mutation is present in more than 95% of patients with systemic mastocytosis, and this mutation turns the wild-type KIT receptor to a mutant KIT receptor that is always on. This constitutively active mutant KIT receptor then has downstream signaling pathways that are turned on. This results in a proliferation of mast cell precursors and an accumulation of mast cells throughout different organs in the body. This includes the bone marrow, the spleen, the liver, could be skin, as well as GI tract. And not only do the mast cells act aberrantly, they look aberrant. And so they're often spindle-shaped or they can be immature, unlike normal mast cells. So what happens when you have too many mast cells in your body, and especially in this case, too many neoplastic mast cells? Well, mast cells can be activated by allergens or bacteria, cytokines, drugs, fungi, peptides, toxins, and viruses, among other things. And these mast cells release mediators, so tryptase, chymase, histamine, different interleukins, and these have a wide variety of activation, essentially, on different organ systems. And that's why patients have such a wide variety of symptoms. So they'll have fatigue and generalized malaise and weight loss, or they may have respiratory symptoms, including nasal congestion and pruritus, shortness of breath, throat swelling and wheezing, and often neurologic symptoms, as we heard from Bree, including migraines, anxiety, depression, decreased concentration and memory, the so-called brain fog. Then there are also musculoskeletal symptoms, such as aches and bone pains, osteopenia, osteoporosis, as well as osteopetrosis. And then there are many patients with digestive symptoms, including abdominal cramping, diarrhea, reflux, nausea, and vomiting. And then, of course, there's the cutaneous symptoms of those patients who have cutaneous involvement of systemic mastocytosis. And so not only do they have those red-brown spots, they have flushing and pruritus, urticaria, and even angioedema. And then finally, there's also cardiovascular symptoms, including hypotension, anaphylaxis, tachycardia, lightheadedness. So, and many of these patients can have all of these symptoms to varying degrees. So how do you diagnose this rare disease? So the diagnosis requires one major and one minor criteria, or at least 3 minor criteria. The major criterion are multifocal, dense aggregates of mast cells in a biopsy. And typically, this is a bone marrow biopsy. And an aggregate is defined as 15 or more mast cells in close approximation. And this is what we do as pathologists, is look at this under the microscope. The minor criteria include more than 25% of mast cells with atypical morphology. I told you that atypical morphology, instead of mast cells being small and round, they become spindled shaped with elongated cytoplasm, or they're immature with kind of bilobe nuclei. The second minor criterion is an activating KIT mutation. Usually this is a KIT D816V mutation, but not always. And then there's aberrant protein expression on these mast cells, which manifests as CD2, CD25, and/or CD30 expression. And finally, these patients can have an elevated serum total tryptase and defined as more than 20 in this minor criterion, unless the patient has an associated myeloid neoplasm, which can be seen in advanced SM. And of course, it's now recommended that you adjust the serum total tryptase for the presence of hereditary alpha tryptosemia. And importantly, there are other diseases that can look like this. So in the absence of a KIT mutation, using appropriately sensitive techniques, you must perform molecular studies to look for other gene rearrangements that are found in other types of neoplasms, and as well as other tyrosine kinase gene fusions. So I've told you there's cutaneous mastocytosis and then there's systemic mastocytosis. And systemic mastocytosis comes in two flavors: non-advanced disease and advanced disease. The non-advanced disease includes bone marrow mastocytosis, indolent SM, as well as smoldering SM. Bone marrow mastocytosis has the best prognosis. These patients have only limited bone marrow involvement. Their serum tryptase levels are by definition less than 125 nanograms per mil. And they have excellent long-term prognosis. Patients with indolent SM are defined as having one or fewer B findings, which are burden of disease findings. And those include organomegaly, like splenomegaly or hepatomegaly without organ damage, or a high mast cell burden, for example, in the bone marrow, or a high serum tryptase level, or a high KIT variant allele frequency. And then the final B finding is dysplasia or myeloproliferation, but not meeting criteria for another associated hematologic neoplasm. So those patients with smoldering SM have more significant disease, and they have two or more of these B findings. But most of the patients are going to have ISM, and most of those patients indeed will have skin involvement as well. And then there's the very rare advanced SM. Most of those patients, in fact, have systemic mastocytosis with an associated hematologic neoplasm. And usually those AHNs are, in fact, other myeloid neoplasms, like chronic myelomonocytic leukemia, or myelodysplastic syndrome, myeloproliferative neoplasms, or a mixed MBS-MPN, and very rarely acute myeloid leukemia. Then we have patients who have aggressive systemic mastocytosis, as defined by having one or more C findings. These are patients who have organ enlargement with evidence of organ damage. And then there's the very rare patients with mast cell leukemia, where you'll have 20% or more mast cells in a bone marrow aspirate smear or involving the peripheral blood. But today, we're really going to be focusing on the non-advanced systemic mastocytosis. So the rationale for targeting disease is going straight to the source. So targeted treatment allows for a reduction in mast cell burden, and Dr. Ryan's going to show you some incredible data which shows evidence of this. So if you get rid of the mast cells, you're decreasing your serum tryptase level, you're decreasing your mast cell mediators. You have less mediators, you have less symptoms, and this gives you the potential for disease modification. So Rafi, I think we have some questions from the audience.
Wow. Thank you, Tracy. Amidst all the bad news in the world, that is actually some hope there. There's some good news. So we're here on the streets. We're going to take some questions. Any questions from the audience? Yes.
Hi, Dr. George, you shared incidents in the US, but how prevalent is this condition worldwide?
So that's a great question. So the question is, how prevalent is this worldwide? So in Europe, I would say that the incidence is probably also the same, very similar, 1 in 5,000 individuals. Indeed, many of these studies have also come from Europe. We don't know what the prevalence is in African and Asian nations. And there's initially was some thought that, do you even see it in Asia at all? But one of my colleagues, actually, Dr. Sebwang Tashi, has organized a group of physicians from Asia who indeed are studying systemic mastocytosis. And so what we're finding that in some other countries where it's perhaps not as prevalent, it's because they don't have the tools to actually make the diagnosis for disease. So if you don't have a serum tryptase level, how do you find these patients? And so that's the challenge, I think, for some African and Asian nations.
Does that answer your question?
Yes, thank you.
Fantastic. Any other? Yes, we got another question here.
So how often is this a de novo mutation? Do you actually see family trees, or I understand it's a kinase gain of function. So are there more de novo mutations?
So that's a great question. So in the vast majority of patients, these are somatic mutations. And so they are de novo and they're occurring in adult patients. There are very rare case reports of young people, babies with what are thought hereditary mutations. But again, those are really case reports.
So do you find the somatic mutation only in the mast cells?
Oh, that's an excellent question. So, do you find the mutation only in the mast cells? So it's interesting. It's complicated. In patients with non-advanced disease, the mutation is primarily in the mast cells. But there's been some really interesting work that came out of Spain that showed that if you had multi-lineage involvement, that is the mutation in other lineages besides mast cells, that those patients, even though they were diagnosed with ISM, actually did worse in the long term compared to those patients who did not have multi-lineage involvement. And what we find, those patients with advanced SM almost entirely have multi-lineage involvement.
And my last question is a challenging question. Why are these cells called mast cells?
Oh, this is a tough one. So why are they called mast cells? So they're called mast zellen, and I believe it was Virchow who first came up with the name of these cells, and looking at them under the microscope with all of these metachromatic granules that fill the cytoplasm.
Those were considered to be fat cells, and in German, mast to mast means to feed high calories to animals to make them fat.
That's right, because the cells look like they're bursting with these granules.
Thank you for that. All right, so if there are no other questions, we're going to take it back to the newsroom. Thank you, guys. Back to you.
All right, so we're going to move on and talk about the breaking developments in KIT inhibition, evidence shaping the future of SM care. And first, we're going to go back and hear from our patient, Bree.
My experience with treatment for my various symptoms. It's been varied, and it's definitely been a bit of a journey. Even before diagnosed, I had obviously, been taking over-the-counter antihistamines or prescribed antihistamines when I was younger, and that was really about it. There was also the occasional diphenhydramine for when things felt a little bit more intense. And then after diagnosis, there was the exploration of additional medications. I had tried nasal inhaled steroids off and on, from my early 30s to later, also inhaled antihistamines and different H1, H2 blockers, and, with various, benefits. Also, there was the attempt with the cromolyn sodium. That's just not something that worked for me, number one, very well, but also that I was able to very much adhere to. I've been very lucky that I've never had true anaphylaxis, and I hope that that's never the case. I still make sure that I do the right things to prevent that possibility or to be prepared should it occur.
All right, so let's move into a discussion about therapies. So I have the pleasure today of discussing some of these options. So I think as somebody who treats patients, the past 5 years in SM care have been particularly exciting. So if we go back before, 5 years ago, we used to treat patients with symptom-directed anti-mediator therapies, and we still use these. You can see here the various symptom buckets that patients have and some of the, again, anti-mediator therapies that are effective for each of these various categories. So if you look at cutaneous disease or rash, for example, oftentimes we'll use antihistamines or mast cell stabilizers to treat patients. This is where anti-IgE therapies can be very helpful. Whereas with other types of symptoms, such as anaphylaxis, obviously epinephrine and perhaps steroids would be more appropriate here. So again, many types of symptom-directed anti-mediator therapies, which we also would classify as best supportive care or BSC medications, which we'll talk about as we move forward and discuss some of the targeted agents that really have come to light over the course of the past, again, 5 years. So I want to take a moment here and just talk a little bit about TKIs, and that's really what we mean when we say targeted therapy within the context of systemic mastocytosis. So how do TKIs work to treat SM? So really, you can see the lovely graph there, and as Tracy mentioned and talked about, what happens in SM is patients develop point mutations which lead to constitutive activation of signaling, as you see depicted here. And so TKIs are targeted therapies which specifically address mutations, such as the c-KIT mutation, and they halt that abnormal signaling. You can see some of the various agents there, so midostaurin and avapritinib, and we'll talk a little bit more in detail. And so I think this brings up the idea of what are our goals of targeted treatment and why are we using TKIs? And so I think what we're doing right now and what we hope to do is, number one, we want to reduce the mast cell burden in bone marrow, and you can get to that via bone marrow biopsy. I'm obviously biased as a hematologist, so we look at a lot of those, which is great. We look at tryptase, so serum tryptase levels. So again, that's a surrogate way to measure mast cell activation as it's released into the blood and can be elevated. We're looking now at KIT D816V VAF, or allele burden, variant allele frequencies. That can be a very helpful marker of disease. And then I think importantly, we're also looking to reduce symptoms. So I think from a quality of life and patient perspective, what you're really trying to do is decrease those symptoms again as a marker of disease burden. And so these are our current goals of targeted treatment, which goes back to actually to the question of disease modification. And so I think that this is perhaps the most exciting slide. So what I think has been really phenomenal and humbling to see is the development of many of these targeted therapies. And so I'm going to walk you through some of these agents. So I think we do have one FDA-approved medication, which is in the US. You can see there it's avapritinib. So this was initially approved in 2021 for adults with advanced systemic mastocytosis initially. And then ultimately in 2023, it did gain approval for patients with ISM, recommended again for patients with platelet counts of greater than 50, initially due to some concerns for bleeding. This was done as part of the phase 2 Pioneer study, which remains active, although is not currently recruiting patients given the FDA approval. And then we have several investigational agents, which I think is perhaps one of the most exciting things within the field, is that not only do we have an FDA-approved option, but we also have more agents that we're studying and in development. So I think we're going to talk a little bit about bezuclastinib. This is another TKI. This is in phase 2 clinical trials in the United States at present. So we'll talk through the data, but the phase 2 summit presented pivotal data this past year, and so this study is currently active but not recruiting, as we're seeing the data read out there. We have elenestinib, another TKI, also in phase 2/3 clinical trial as part of the Harbor study. This study is currently actively recruiting. And then we have agents that work with different mechanism of action. So not only do we have TKIs, we're also thinking about other types of mechanisms. So TL895 is an agent that's being used in combination, in combined studies actually, phase 2, and this is a BTK inhibitor looking at ways that we can really prevent and alter mast cell activation in patients. So let's walk through some data. I think this is the exciting part. So let's go first to Pioneer, since this led to the approval of avapritinib. So this was the study that led to this approval. Again, this is avapritinib versus placebo in patients with uncontrolled moderate to severe SM and indolent SM. Patients were randomized in 2-to-1 fashion to receive avapritinib 25 milligrams once daily versus placebo, and in both scenarios, patients received BSC, or best supportive care medications. If you look at the primary endpoint here is the mean change in what we call the total symptom score. So to get to the total symptom score, we use patient-reported outcome assessments. So really ways that we look to patients to define their symptoms and assign a number to it. So that was the primary endpoint of this study. And patients did have an opportunity to roll over into a part 3 where they received avapritinib with best supportive care medications daily. If you look at eligibility, you can see there that patients had to have ISM confirmed by central pathology review. There was no restriction on prior therapy, and patients must have had moderate to severe symptoms on at least 2 BSC medications. I think the important take-home points here, again, are the primary endpoint, which is the mean change in total symptom score, or TSS, and then various key secondary endpoints, which again assess symptom reduction, very important from a quality of life perspective. And then my personal bias, what I find most exciting, the various markers of burden of disease. So looking at decreases in serum tryptase, bone marrow mast cells, and then that KIT D816V VAF, which we'll walk through. All right, so let's look at the primary endpoint. So this is the primary endpoint of this particular study, and you can see that patients who received avapritinib in comparison to placebo had a statistically significant decrease in their mean total symptom score, again, in comparison to patients treated on the placebo arm of study. So this was studied over the course of 24 weeks. That was when the primary endpoint was assessed, and patients then had an opportunity to cross over to receive avapritinib if they had previously been on the placebo arm of the study. And you can see that very nicely depicted here, again, with the significant value to this reduction in symptoms. So this study met the primary endpoint and also had an impact when it came to various secondary endpoints. So again, these are markers of disease burden. So we're going to look at the reduction in serum tryptase and then the peripheral blood KIT D816V VAF. So if you look to the left, you'll see that the patients there had to achieve at least a 50% reduction in serum tryptase, and you can see that 53.9% of patients achieved this with avapritinib in comparison to no patients who received placebo. That was obviously statistically significantly different. Again, if you look at the peripheral blood KIT D816V VAF, you'll see that depicted to the right. We note that 67.8% of patients achieved this endpoint, in comparison to 6.3% of patients in the placebo-controlled arm. And then you can also look at the bone marrow mast cell burden, which is not shown in graphic representation, but was statistically significantly different between these two groups of patients. And then I think, again, when we look at other various markers of disease and impacts of disease, you can look at things like rash or skin lesions. And I think this is a really lovely depiction of how patients responded from the perspective of their UP or urticaria pigmentosa, which is the classic rash that we see associated with systemic mastocytosis. So these are pictures at baseline for patients pre-exposure to avapritinib, and then subsequent pictures at week 24 after patients had been exposed again for that period of time. And you can see, I think here, a significant notable decrease in that skin rash for patients. So obviously impactful when it comes to quality of life and how patients feel about their disease and various other aspects of how patients feel. So we can't talk about novel therapies without talking about safety. This is an important aspect of these treatments. And so you'll see the safety profile of avapritinib listed here. What we note as part of this study is that a majority of the AEs were grade 1 or 2, so low grade with a very low rate of discontinuation. SAEs, interestingly, were reported more frequently in the placebo group, which I thought was interesting. And then we also did see there various AEs, which you can kind of follow in the table. What we did note is that edema adverse events were higher in the avapritinib group. Again, a majority of these were grade 1, and you can see there that there was a higher incidence of peripheral and periorbital edema in the patients who had received avapritinib. And so I think all suggestive that this is an agent with a favorable safety profile, which obviously was moved into clinical practice. And so I think moving forward and kind of thinking about what's coming up the pipeline, I think in medicine, there's always this push to do more and to provide options. And I think it's really been interesting and exciting to see more options for patients. And so I want to talk a little bit about the SUMMIT trial. So this was presented this year at ASH. This was the pivotal phase 2 multi-center randomized double-blind placebo-controlled study, which looked at bezuclastinib, which is another TKI specifically for patients with non-advanced SM. So if you look to the left, you'll see the eligibility here. So this particular study included patients with indolent systemic mastocytosis across 3 different categorizations, so ISM, bone marrow mastocytosis. And I think it's important to note that this also included patients with smoldering systemic mastocytosis. So this is really the first trial which has included this particular subgroup of patients within the context of the eligibility. Again, patients had to have inadequate symptom control, so moderate to severe symptoms on at least 2 previous anti-mediator therapies. And you can see the various BSC medications that were included there. So patients as part of the SUMMIT study were randomized again in 2-to-1 fashion, either to bezuclastinib at the chosen dose of 100 milligrams daily versus placebo, again in combination with best supportive care medications. Patients were enrolled into part 2, and that's the data we'll discuss, and then also had an opportunity to enter an open label extension period. And I think, again, if we talk about the endpoints, the primary endpoint was the mean change in total symptom score, which we'll see. And then you can see the various part 2 endpoints, which are listed to the right. So again, reduction in various markers of disease burden, as well as some alternative ways to think about the reduction in total symptom score. And again, these endpoints were assessed after 24 weeks of exposure to bezuclastinib. And so this is the primary endpoint data, and I think what's interesting here is you find that the patients who received bezuclastinib achieved a significant and statistically significant reduction in their total symptom score. So this was a placebo-controlled effect size of almost 9 in comparison, again, to the placebo arm of the study. Again, this represents a rapid, as early as 4 to 6 weeks on therapy, and durable response, again, with the primary endpoint being positive for this particular study. This is, I think, is an interesting way to also look at this data. So when we think about total symptom scores for patients, there are various symptoms and domains where people experience symptoms as part of indolent SM. And so this particular study used a patient-reported outcome tool called the MS2D2. So this was a fit-for-purpose tool whereby patients scored their various symptoms across 4 domains and answered really in 11 different symptoms that were included as a part of this measure. You can see at the top of this particular image the various symptoms that are included as part of the MS2D2 score calculation. And they, again, cross 4 different domains, so skin, fatigue, neurocognitive, and other. You can see them listed out there. And what I want to point out is that if you look, all of these symptoms really had a statistically significant difference, with the exception of 2, when patients were exposed to bezuclastinib, again, in comparison to placebo. And so what this really tells us is that this particular agent works broadly across symptoms and symptom domains, and it's not one particular symptom that is driving this decrease in total symptom score. And so again, I think this is important, as we previously discussed, given the heterogeneity of clinical presentations in patients with an ISM. All right, so I'm going to get to my favorite part. I know, I can't help it. It's the hematologist in me. And let's talk about those markers of mastocytosis and burden of disease. And so one of the key secondary endpoints, again, was this change in the decrease in serum tryptase. And I really like, this is actually from Tracy's presentation at ASH this year. This was really, I think, a lovely way to look at the change in serum tryptase. So you can see the gray bars in this graph really depict the tryptase at baseline for patients. And if you look at the darker bars in this particular plot, you can see that this was the change within each patient in that serum tryptase. So what we found, again, this was a statistically significant secondary endpoint. Among the 89 bezuclastinib-treated patients with an elevated serum tryptase to greater than 20 at baseline, 83% of these patients achieved a normalization of their serum tryptase to less than 20 at the 24 weeks. And if you look at the 104 patients, again, receiving bezuclastinib who had a serum tryptase elevated to at least 11.4, 78% of those patients, again, achieved normalization. So really a significant change there in this key secondary endpoint. And I won't go through the graphic representations, but I do want to talk through these other secondary endpoints. So when we look at the bone marrow mast cell burden and, again, the abnormal mast cell phenotype, what was noted is that 88.2% of patients treated with bezuclastinib had at least a 50% reduction or clearance of mast cell aggregates in bone marrow. Tracy had a lovely presentation at ASH this year. Again, hematologist. Looking really at the phenotype and the pathologic changes and how those change within the bone marrow. And so there's that interesting data. When we look at the KIT D816V variant allele frequency, or VAF, it was noted that 97.5% of patients who received bezuclastinib had at least a 50% reduction in that in comparison to no patients in the placebo-treated arm. I'm going to go back to that subpopulation that we mentioned before. So patients with smoldering SM and patients who had had prior exposure to avapritinib really had similar meaningful improvements in their symptoms and the objective markers of disease, again, suggesting that this is broadly applicable. And I think this really is the first study to look at the magnitude of symptom improvement and how that correlates with some of these markers of mast cell burden. And so that was another aspect to this particular study that was investigated. So again, we can't have a discussion about therapies without talking about safety, and so here's the safety data listed here. With bezuclastinib in particular, we find that the majority of treatment-emergent AEs, again, were low grade, so grade 1, and reversible with cessation of therapy. Again, there was a variety of AEs that occurred more often in the placebo group in comparison to patients who received bezuclastinib. There was a low rate of cognitive impairment adverse events, no incidences of bleeding. I think the important thing to note there is that has been a concern in other agents. And I think if you look to the left, what you'll find is the most common treatment-emergent AEs, which we've seen in the context of this study, with a note that 69.5% of patients do have hair color change. That would be the most common treatment-emergent AE that we found, followed by altered taste and some other gastrointestinal side effects. I want to take a moment just to look specifically at the ALT and AST changes that were noted. So there were 11% of patients who did require dose modification. 5.9% of patients experienced a grade 3 transaminase elevation, but no patients required hospitalization or cessation. And all treatment-related discontinuations due to the transaminase elevations fully resolved with cessation of therapy. So again, I think this also suggests that there is a favorable safety profile with this particular agent with some, I think, notable interesting side effects, including that lightening of the hair. And then what I think is probably most exciting. So again, I think it has been humbling as a clinician and as an investigator to see the field change and just expand. And this is a list here of all the data that was presented over the past few days at AAAAI in 2026. And I think it's amazing that there were this many abstracts focused specifically on systemic mastocytosis. And I think this really is going to have us thinking about some of the longer term implications. So if we look just briefly through these, I want to point out just a couple of abstracts of particular interest. So I think there is now a lot of discussion about how these c-KIT and targeted therapies may impact longer-term complications of ISM, which would include osteopenia, osteoporosis, and bone health. And you can see here 2 abstracts that were presented looking at that. There's longer term data. And again, a lot of really, really wonderful abstracts and a lot of interest in the field, which I think is very exciting. So with that, I'm going to turn it over to more questions from our audience.
Thank you, Lindsay, for that expert dive into clearly a lot going on in the world of mastocytosis. And so now we'd like to ask how our audience would define treatment response. After seeing all that data, anyone have insight or want to comment?
All right, well, if it makes anybody, if it makes anybody feel any better, I don't know that I know the definition of this either. So I think this is a great topic, right? So I think you've hit the hot topic and the hot discussion point within the field. And again, it's because of these studies that we're able to ask these questions. So I don't know, Tracy, from a pathologist perspective, how are we going to define it?
Yeah, as a pathologist, I want those mast cells to go away. And that's exactly what I'm seeing in these clinical trials, which is pretty exciting, is that not only are the mast cells going away, but the biomarkers of mast cell disease. That includes serum tryptase levels dropping, as Lindsay just showed, the peripheral blood KIT variant allele frequencies dropping. So to me, that defines treatment response. But of course, I'm not treating these patients. So I know, Nate, you're going to have something different.
From my perspective, the bone health, as Lindsay, you mentioned, as being such a critical part of the health of these patients. And I always think of this diagnosis as one that can lead to a heterogeneous group of manifestations. And so not everybody will have the same disease manifestations, but when they do have them, they are important for the people that do have them. And so to have a vertebral fracture for those people, that is a big issue. So I think from their perspective, they would probably want to see a treatment response be improvement in bone density and improved bone health. The skin lesions, I think, are a very important treatment response, and how you would define treatment response and, frankly, complete resolution of the skin lesions. And I think we're seeing that now with some of these agents. So the skin lesions, the bone health, anaphylaxis as the third one, probably the more difficult one to study in a clinical trial. And the major outcome of these trials, which is the total symptom score, and as you saw with the data, that I think that the treatment response looks good for a lot of these agents. So the combination of those.
So that's treatment response, but I guess, that leads into what is treatment success?
So, I think that's a $1 million question. But I think this is really where you have to consider what it means to different people, right? Yeah. So again, I'm a hematologist, so I too enjoy seeing no mast cells on bone marrow biopsy samples. But I think you also have to consider from a patient perspective what that means. And so I think what has been phenomenal as somebody treating these patients is to see that quality of life and symptoms have really been impacted, and people have gone from not being able to do things that they want to do to be able to do things that they want to do. And so I think treatment success is probably defined per patient, looking at a combination of symptoms and pathology.
Yeah, it's interesting because on these trials, what I'm seeing is bone marrows look normal after treatment with some of these agents. That's pretty amazing. The serum tryptase levels are normal. The KIT VAF becomes undetectable. So to me, that is treatment success, right? If the neoplastic mast cell is the cause of these disorders, get rid of them.
That's great color commentary. We've got a question right here.
Oh, excellent.
Hello, I'm Professor Mike Rodenko from the London Asthma Immunology Centre in London, UK. A very interesting development in the systemic mastocytosis. I just wonder, did they look at the neurological symptoms, at the brain fog that you mentioned in the beginning? Is it changing at all in these patients on treatment?
Yeah, so there's improvement in symptoms across essentially all of them, and especially the SUMMIT trial that Lindsay went through, where you see the individual symptoms have a significantly significant improvement in the individual symptoms in addition to the total symptom score.
Does that answer your question? Fantastic. We've got another question down here.
Hi, thank you very much. I'm Professor Jorge Maspero from Buenos Aires, Argentina. All the patients I have diagnosed with systemic mastocytosis came to my attention due to anaphylaxis after Hymenoptera sting or a fire ant sting or whatever. And the question a patient will ask me if I try to give him this drug or the payers of his or her HMO is, but this new treatment should reduce the risk of subsequent anaphylaxis, or should we still keep giving these patients imatinib and omalizumab as is our current practice?
So it sounds like the question is whether to continue immunotherapy in patients with Hymenoptera venom allergy if they are on a tyrosine kinase inhibitor. Is that right?
We are not keeping these patients on immunotherapy because our ethic committee doesn't allow a patient with 4 or 5 anaphylaxis at that risk to have immunotherapy. But we give them omalizumab and imatinib at this time. We are now moving to the new drug when it is available. But the question is, with imatinib alone, we couldn't stop the anaphylaxis after the stings. Combining with omalizumab, yes. And the question I anticipate from the payers, from the HMO is, okay, are we saving the cost of the omalizumab, or we'll still need to keep it in these patients?
So, yeah, that's a great question. I don't think that any of the current tyrosine kinase inhibitor trials have assessed anaphylaxis as a secondary endpoint or obviously primary endpoint. So I think for patients with Hymenoptera venom anaphylaxis, the typical treatments, the standard of care would be immunotherapy. And for patients who have challenges with just immunotherapy or they have side effects from immunotherapy itself, then omalizumab may be a palatable option. I would encourage people to look at the symptom assessments, the symptom scores that Lindsay has talked about, including the ISM-SAF and the MS2D2 and the mast cell control tests and others, because patients may have symptoms that may be more than they are necessarily revealing. So if they have fatigue, diarrhea, neurocognitive symptoms, I think it's important to take, assess that and ensure that, in my experience, I think most patients actually, first-line therapy with tyrosine kinase inhibitors is actually, that's how I practice. So we, of course, show them the whole, catalog of what they could have, and most of them go to a tyrosine kinase inhibitor. Yeah.
Thank you for that. And now back to Bree for another segment. Thank you.
I think treatment success is a very personal marker, a personal goal, if you will. I think we all kind of determine what our new normal is and what we feel like is improvement upon that. I had come to accept what my symptom burden was and how that impacted my life. So to have the opportunity to re-engage differently in my life and to not have the same concern about how is this going to impact me, how am I going to feel in a couple of hours, or is something going to trigger a reaction that I'm not prepared for. So for me to move beyond that at all was a level of treatment success. But I think, that varies by patient, and I've experienced as engaging with other patients with systemic mastocytosis that everybody kind of does view their symptom burden differently and the impact in their daily life and their daily activities. So I think it's an important thing to identify with your caregiver, with your provider, and define what you want that success to look like. And, for me to reduce my dependence on other medications and to re-engage in my life was symptom treatment success.
Great. I think we're on to the next segment now. Reframing treatment control, what stability should mean in modern SM care. Sorry, there we go. Okay, we have two cases to talk about today. This is the first case. This is a 54-year-old man with no prior fragility fractures who presents after a low-energy fall from standing height and has acute left wrist pain. He reports several years of intermittent flushing, abdominal cramping, diarrhea, and chronic back pain. The skin exam is unremarkable. He has no history of kidney stones, anemia, corticosteroid treatment, low libido, alcohol use, or opioid use. On exam, he has no splenomegaly or hepatomegaly. A plain radiograph of the left wrist shows a displaced distal radius fracture. A subsequent DEXA scan shows a lumbar spine T-score of -3.1, a total hip T-score of -2.9, and as you guys may know, that falls within the range of osteoporosis for a man who's 54. And so the combination of the left wrist radiograph and DEXA results are consistent with a fragility fracture. The initial lab work is shown here. A CBC was within reference range. A complete metabolic panel was also within reference range. Vitamin D levels were, again, within the reference range, as you see. Same with PTH, TSH, total and free testosterone, and then an SPEP, immunofixation, with free light chain ratio showed no monoclonal protein or skewed light chain ratio. In terms of mast cell-related testing, this patient's serum tryptase was 14 nanograms per milliliter. The reference range is less than 11.4 nanograms per milliliter. There's a test that many of you know called hereditary alpha-tryptosemia testing, but actually another way of saying it is what is written here, which is TPSAB1 copy number variation testing by digital droplet PCR. And the result of this was that this patient did not have hereditary alpha-tryptosemia. They had 2-alpha, 2-beta, which is a normal tryptase genotype. And finally, a urinary N-methylhistamine urine test showed a value of 199, and that fell within the reference range. And additional imaging included a CT without contrast of the cervical, thoracic, and lumbar spine because this individual reported back pain. And it was found that there were multiple vertebral compression deformities with associated vertebral body height loss of the thoracic and lumbar spine. And then bone marrow biopsy evaluation was performed. And what was found? Well, as you might guess, there were multifocal dense aggregates of mast cells in the bone marrow, comprising 10% of the cellularity, which is a fairly typical amount for someone with SM, and that's what Lindsay showed you with the data from the studies. A majority of the mast cells exhibit spindle-shaped morphology. Immunohistochemistry and mast cell flow cytometry testing showed mast cells had aberrant expression of CD25 and CD2 by both methods. The driving mutation, KIT D816V, was detected by digital droplet PCR in the bone marrow at 0.3%. A myeloid next-generation sequencing panel showed no additional pathogenic variants, or what we would call tier 1 or tier 2 variants. So based upon this, the pathologists on this case informed us that 1 major and 3 minor WHO 2022 criteria were met for the diagnosis of SM, and that the findings in clinical history were most consistent with bone marrow mastocytosis because this individual did not have skin lesions, as well as several other things, but the absence of skin lesions was important for the bone marrow mastocytosis diagnosis. So we have a question for you guys. What therapies would be considered in this situation? And I think we're actually asking our panel this question, if I'm not mistaken. Not you guys. So I know I have a view. I have a view on what therapies could be considered, but I would think, why don't we start with Lindsay, and then we can go around the table here.
Well, I think we kind of alluded to this earlier when we looked at the abstracts that are being presented and some of the things we're thinking about. So, I mean, obviously, in a patient with osteoporosis, a male in his 50s, you'd want to think about treating that. So that's number one, most important. We're going to treat that, bisphosphonates and other agents. But I think this probably leads us to the question of whether or not we should be thinking about c-KIT inhibitor therapy in this scenario. And I think what we're seeing, perhaps in some of the data presented, is that there is an impact of these agents on bone health. And given that, again, we're looking, especially in indolent SM, at long-term chronic diseases, where patients aren't necessarily going to have an impact in terms of life expectancy, but really are going to be impacted in terms of their quality of life and what they live with. I think this is an important consideration of whether or not c-KIT inhibitor therapy is indicated. And so I would definitely consider it in this particular patient.
Yeah.
Yeah, so I mean, obviously avapritinib is the only FDA-approved drug right now, or you can put your patient on a clinical trial for either bezuclastinib or elenestinib. And then there's also the trials with the TL895. Right. So, you know, any of those I think are options.
And at the present moment, the SUMMIT trial for bezuclastinib is closed to enrollment, but there is an expanded access program which people can view different sites on clinicaltrials.gov. And so although bezuclastinib is not currently FDA approved, patients do in fact have access to it if they're close enough to the site that it's a reasonable option for them. So it seems like you know, the consensus, I think, probably among us three, is that a tyrosine kinase inhibitor therapy would certainly be an important consideration for this patient to think about in their decision making. I parrot what Lindsay has said with the bone health. I think this is a very good case of an individual where the bones really do matter. And so there were 2 posters at this very session, and so I think the things that I think about with a patient really are, you know, how quickly will they get to where they want to go? How many side effects will they have? And so I think essentially laying out what the side effects are of the agents. With avapritinib, we see more edema. With bezuclastinib, there is hair lightening, although the speed and depth of remission seems to be more in that case. And I think that's the objective biomarkers are showing. So I think those 2 are great options. But some patients may still have questions, and they still may want to consider other alternatives. There's also the typical treatments for osteoporosis. And I think in my discussions with endocrinologists, their typical desire is to treat the underlying cause first. And so even though they may have bisphosphonates on the table, they may have Prolia on the table, actually they may actually have a strong preference as well for a disease-modifying agent that targets the underlying disease.
And Nate, you alluded to the 2 posters that were presented at this meeting on Quad AI and bone health. Do you want to talk about them a little bit more? Because it's pretty remarkable data.
Yeah. So, you know, again, for the patients that have the bone fractures, it really does matter for them because they have substantial pain from it, and in some cases may have a disability from it, whether it's a wheelchair or using a cane. And so I think the data. So I had the privilege of presenting the Summit bone data at the conference here, and so what we see are improvement in T-scores on bezuclastinib treated patients. And assessing, comparing time point 0 prior to treatment as well as at week 24. And we see a significant increase in the bone density in the lumbar spine, which is actually where most of the fractures will occur in patients with SM. And 2.5% increase, I believe, was the number on the poster. And so actually just keeping a stable density in many people's minds is a win, because as we get older, our bones get less dense. And so, but in this, you know, generally speaking, you know, checking bone density is usually done once a year, sometimes longer than that, every 2 years. So the fact that you're seeing this increase in such a short period of time, I think, speaks to the potential value of this agent in this type of population of patients.
And the Pioneer data?
The Pioneer data, actually, I didn't get to look at that poster as closely. So
the Pioneer data shows similar findings with improvements in bone marrow density in patients, and I believe also within that 6-month period. So really exciting that these selective TKIs appear to work for this indication.
Yeah.
But I think that speaks to the point of again, really targeting the underlying driver, right?
Yeah.
So instead of treating the manifestation of disease and what's happening, to really target what's causing it. Again, supporting the argument that these have a role in this, for sure. Yeah.
And of course, this patient had not just the bone concerns, but there were additional concerns that I think, the TKI treatments could help with. Okay, so second patient. This one is a little bit younger, a 46-year-old woman with a history of anaphylaxis and five years of reddish-brown macules with associated pruritus, as well as fatigue and flushing. She has a history of anaphylaxis after fire ant stings, which I believe we had a question earlier about a person with fire ant allergy, with syncope in the absence of urticaria. And in this event, she required field administration of 4 epinephrine autoinjectors, which is not uncommon for patients with SM. Numerous reddish-brown macules on her trunk that urticate with exercise, persistent fatigue, as well as intermittent flushing, and she has no reported alcohol use or rosacea. And her medications are shown here: antihistamines, omeprazole, an antidepressant, and a non-steroidal anti-inflammatory. And she had a skin biopsy of one of the reddish-brown macules, and this demonstrated increased dermal mast cells to the level that can be seen in conditions such as cutaneous mastocytosis. And in this case, because she has not had a bone marrow biopsy, at least in this slide, we would call it mastocytosis in the skin. And so her laboratory values are shown here. She has a serum total tryptase of 10. And again, the reference range is less than 11.4. Her TPS-AB1 copy number variation testing by digital droplet PCR, which again is a test for hereditary alpha-tryptosemia, showed a normal tryptase genotype of 1-alpha, 3-beta. And the 24-hour urinary N-methylhistamine results are shown as 190, again in the reference range, just like the last patient. The KIT D816V mutation was not detected by digital droplet PCR of blood. And then additional laboratory testing was within reference range, including those shown. And again, no splenomegaly or hepatomegaly on physical exam.
I think she needs a bone marrow biopsy.
Right, she might need a bone marrow. She might just need a bone marrow.
Well, I think it's interesting, right? Because maybe we should ask the audience. I mean, the peripheral blood KIT VAF is negative, right? Does that mean she doesn't have systemic mastocytosis?
Raise of hands.
As the mast cell in the lesion, not in the blood.
Yeah,
And that's a new concept, that mutations can actually be so localized that you are not going to find it in the bone marrow or in the peripheral blood.
So you're absolutely correct. There's, again, excellent data that's come out of Alberto Orfal's lab that shows discordance between the presence of the KIT mutation in blood versus bone marrow for different subtypes of systemic mastocytosis. So for those patients who have bone marrow mastocytosis, there's a discordance rate of 50%. So 50% of the time, the blood will be negative, but the bone marrow will actually be positive. And the discordance rate in indolent systemic mastocytosis is 15%. So 15% of the time, the blood will be negative, but the bone marrow will actually be positive.
By show of hands, who did not know that and obviously would change their parameters, knowing this information, valuable information? Yes. Excellent. Yeah, great conversation back in the newsroom. Considering these patients, the examples you gave, Nate, both have the markers potentially, the pathology, and what's important to the patient often is, I don't care what kind of stuff you're finding, it's my symptoms that I need you to improve. And it's exciting at the street level to at least know that we've got therapy and potentially more therapies in the pipeline on the horizon.
And I think this is a great case to show that if somebody has mastocytosis in the skin, that they really should be offered a bone marrow biopsy regardless of what Dr. George just mentioned of the negativity of the KIT D816V testing of the blood, as well as tryptase, because as you saw, the patient's tryptase was not above 11.5. And so, so really what's driving this are, there's two things driving this person's recommendation from us to get a bone marrow, which are the skin lesions, as well as actually the anaphylaxis. Now, would you offer a bone marrow to everybody who has fire ant anaphylaxis? No. And I think the Spanish group is going to come up again because they came up with a really great anaphylaxis scoring system called the REMA score, which it really heavily weights syncope and the absence of urticaria in how the anaphylaxis appears in patients with SM. And so their anaphylaxis does look distinct, and it's hard to miss, if you ask me, because it actually, you might think they're having a heart attack or something else because you don't really see the hives, you don't really see lip swelling. And so in this patient, even if they hadn't had the skin lesions, they would have been offered a bone marrow, even if they, and then on the flip side, they would have been offered a bone marrow for the skin lesions. So they really have two reasons to get a bone marrow.
Yeah.
I think this brings up an important point, which I think we've talked about today. At some point, I mean, really cutaneous only disease, I tend to think of more as a pediatric disease. And so when we see that classic UP, that classic macular rash of systemic mastocytosis, I personally offer a bone marrow biopsy to all those patients because if you look at the rate, I think, of cutaneous only disease in adults, you're looking at maybe 5% of patients. And so I think a vast majority of patients with skin lesions do have a bone marrow involvement. And so it's not just because I'm a hematologist, but I do think in those patients, there is a role for making that diagnosis. And again, that impacts, I think, how we manage patients longer term. So,
Yeah.
So I remember a patient many years ago when I was practicing at Stanford, and they said, Dr. George, we've got a patient with TMAP, this rare variant of cutaneous mastocytosis. I said, that's great. Your patient has systemic disease. They need a bone marrow. And sure enough, they got a bone marrow biopsy and they had indolent systemic mastocytosis. Now, since that time, there's been multiple publications out there. So adults with cutaneous lesions of mastocytosis all need a bone marrow examination. And in my opinion, even if the bone marrow is negative, you got to watch those patients carefully. Because maybe they have a very minimal amount of disease and you're just not catching it in that bone marrow. So maybe a year later, you need to then follow up with another bone marrow, make sure they don't have systemic disease.
So I think we're going to get to the interesting part of this case now. So this patient had a bone marrow biopsy, a bone marrow aspiration and core needle biopsy, and the first thing you'll see is that there was an absence of multifocal aggregates of mast cells in the core biopsy. So the major criterion was not met. Mast cells comprised, however, 5% of the cellularity. A majority of the mast cells actually did exhibit spindle-shaped morphology. In two techniques, immunohistochemistry and mast cell flow cytometry, mast cells demonstrate aberrant expression of CD25 and CD2. By both techniques. So now they're at two minor criteria. And lo and behold, KIT D816V was detected at the absolute lowest level it can be detected by ddPCR at 0.03%. And so this patient, in fact, has systemic mastocytosis based on those three minor criteria. Many institutions will do a myeloid next generation sequencing panel as a standard to ensure that there are no additional molecular changes that could be informative for their care. So this person had no additional variants.
Can I jump in here?
Yes, please.
Yeah, so this is getting to the sensitivity of KIT testing. If you only tested this patient for next generation sequencing, that's the myeloid next generation sequencing panel, and you'd say they don't have KIT. But remember, the sensitivity of that assay is to anywhere from 2 to 5% variant allele frequency. This is somebody with a minimal amount of disease. Their KIT VAF is 0.03%. That's not unusual. So you have to make sure that you're getting the right test when you're looking for KIT D816V. And so doing a sensitive test that has a limit of detection of 0.01% to 0.03% is absolutely critical. Because if you don't look for it hard enough, you're not going to find it.
I think this actually highlights another critical point, which I think is important to bring up, that you really do have to, and I think this is where having access to an expert or somebody who looks at bone marrows for systemic mastocytosis is also key, right? So making sure you have somebody familiar looking at this, whether it be through a center of excellence, which there are, at least in the US, many of those centers, to make sure that diagnosis is being identified, number one, and that the correct testing is being sent. Because I think oftentimes a common referral I see in practice is a patient who comes in, bone marrow is done, looks just like SM, but the KIT mutation is negative. And the most common answer, honestly, is the incorrect testing was sent. And so.
Right, and this gets also to the point of there were no mast cell aggregates. So these are the types of cases I receive in consultation. I'd say 10 to 20% of patients with ISM don't have aggregates. That's what we've seen in the clinical trials. But they do have abnormal mast cells. But those mast cells, you're going to need immunohistochemistry, you need to do CD117 staining, mast cell tryptase staining, CD25 staining, to find those mast cells in those bone marrows. Same thing with the flow cytometry. Any old flow cytometry isn't going to find this. If you're just doing your regular leukemia, lymphoma flow, you're going to miss these cells. You need to have a tube that's specifically testing for mast cells. And so it's more of an MRD type assay where you collect over 1 million events. You have to collect that many events in order to actually see if the mast cells express CD25, CD2, and often CD30. And
you guys, I think the value of a diagnosis is obviously very important for the patients, because if let's say they get a diagnosis that is not as well defined, monoclonal mast cell activation syndrome, or another one would be cutaneous mastocytosis in an adult, which is very rare, and so those are diagnoses to generally get second opinions with. Yeah. And so someone like a Dr. George at ARUP, or your other pathologists who you go to, I mean, those are, because these patients, I think, will be blocked from getting disease-modifying therapy, such as a TKI, if they do not get a diagnosis.
So you raise a really good point. So in Europe, they have the European Competence Network on Mastocytosis, and they've had that for well over 20 years. So there are centers of excellence, in each country across Europe. So we established back in 2019 AIM, or the American Initiative in Mast Cell Diseases, so that we could have centers of excellence throughout the Americas. And we've got more than 30 actually. And to be a center of excellence, you have to have hematologists, allergists, and pathologists who are experts in mast cell disease. So we're trying to increase the number of centers throughout the US, as well as South America and Central America, so that patients can get a diagnosis.
So I think at this point, the question is, what therapies would be considered in this patient in this situation? And so I think we've heard of some of them already. So again, the patients are the ones making the decision, but people like us generally spell it out for them. Here are the options, here's the data, and we run through the data with them. And so right now, as we all know, there's one FDA-approved product, which is avapritinib, and that's the one in terms of the tyrosine kinase inhibitor. But again, there's the expanded access program for bezuclastinib. I think some of the very exciting data of the correlation between the improvement in symptom and the improvement in pathology coming out of the bezuclastinib study, I think is truly compelling. And the patients that I talk to, they actually are drawn to that, I will say, the connection between the pathology improvement and the symptom improvement in terms of the magnitude of it.
So you make a really good point here. So you could argue, right, well, the patient only has 5% aberrant mast cells in the bone marrow. What's normal? Normal is well less than 1%. So even with 5%, what you're seeing in these clinical trials is these patients are going down to less than 1%. So that's pretty dramatic. But of course, the most important thing is, to the patients is the symptoms. So that's what you really want to address.
I think the other thing to think of, I don't think we think of rash as a symptom all the time. It's more of a it's a physical exam finding, right? But there are certain things like that macular rash, which can be very impactful from a patient perspective. I think it's important to keep note that a larger proportion of patients with ISM are women, and that can be really impactful when you think about quality of life and a whole bunch of different aspects. So I personally think that there is a huge role for c-KIT inhibitor therapy for that UP rash, because we really do see the difference. And I think we saw that slide with the avapritinib data looking at that change in that rash. So.
Yeah, and it seems like from the patients that I see, there's different distributions of the skin density of the lesions. And so we didn't actually say what the density of this patient's lesions were, but you can imagine, for some people, even a low amount of the lesions are bothersome, and of course they're symptomatic. And so if they take a hot shower or they're exercising or whatever the trigger is for the lesions to urticate, it does bother them a lot. And then the cosmetic aspect is also very important, especially depending on the age of the person and depending on the density of the lesions. The fact that these treatments, the TKIs, are driving it away, driving the lesions away, that's very appealing.
It's pretty impressive to hear stories from physicians who are taking care of these patients on the clinical trials, and how they say that their patient cried because she was finally able to go to the beach with her family for the first time.
Yeah, 100%.
Yeah.
Or you feel better. I mean, North Carolina summer, right? It's hot. It gets hot. But it's amazing. People won't wear shorts because they're bothered by the rash, and now you've got patients who are doing that, and it just changed their life.
That is a common story.
Yeah.
The not having to cover up.
Yep.
They're covering up with more clothing. So
I guess now it's back over to you, Rafi.
Yeah, thank you. This was, we have an expert panel here, and it's a treat for our audience, both live as well as those of you at home or at work remotely joining us. So get those questions rolling. I'm going to kind of poll the audience. Any thoughts about these cases? We've got it.
One question for Dr. George and two more questions for anybody. The first question, some of these patients have undergone intestinal biopsy. They've seen the gastroenterologist. They have gone through everything, colonoscopies, endoscopies, and we end up having biopsy specimens. I have talked in the past with pathologists to see if they can get out the specimens and check for CD2, CD25, CD18, and I stopped doing that because I was getting conflicting results and comments. Pathologists were telling me, well, if it's 40 and above, it's okay in the intestine, but maybe in the esophagus is... So it was never helpful, and I was not sure if this is something that needs to be entertained, because a lot of those patients did have biopsies because of this. So that's my first question to Dr. George. Is this worth doing it?
Absolutely.
Okay.
So to diagnose, systemic mastocytosis, we went through those criteria. Usually it's done with a bone marrow, but it can be any extracutaneous organ. So certainly I've diagnosed my share of patients with GI biopsies. It's not so much the increase in mast cells in the GI biopsies, it's their architecture. You get linear array and clusters of mast cells in systemic mastocytosis in the gut. And they have a specific phenotype. Now, they express KIT, but they are dim to negative for tryptase. So by immunohistochemistry, and then they're CD25 positive. So it's that pattern of staining, which is so critical. And so if I see a number of increased mast cells, but they're not aggregating together, and they're just increased, that can be anything. That can be irritable bowel, that can be a number of different conditions. But when they're aggregating together, they're bright brightly positive for CD117, they're dim to negative for tryptase staining, and then they are CD25 positive. That is systemic mastocytosis. Now, what I can't tell you based on a GI biopsy is what is the subtype of disease. And so you do need to do a bone marrow examination in order to figure out which subtype it is, as well as correlate with, laboratory findings, physical exam findings. So that's absolutely critical. But it's been well published, but maybe it's not been well publicized amongst all pathologists. What do you see in GI mastocytosis? But it's very distinct. There's an interesting study that came out of Andreas Reiter's group where they tried to subtype the type of systemic mastocytosis based on GI biopsies. Couldn't do it. So that tells me a GI biopsy can help you establish disease, but you still need to do the bone marrow. Hope I've answered your question.
Yeah, Tracy, this is valuable information because oftentimes that's the piece that might be missing, and the clinical index of suspicion goes up by ordering at least the biopsy that the GI specialist is doing so that you're getting the patient on the right track. So at this moment, I'd like to throw it back to our newsroom for the next segment.
Okay, so our first question is, what is the role of TKIs in allergy immunology practice? Okay.
I think that's you.
I think that one might be me. Well, I guess I would start off by saying that allergists have this, so systemic mastocytosis is not the first myeloid neoplasm that allergists have helped with, and in particular worked to bring TKIs to the table for the neoplasm. So you might have heard of hypereosinophilic syndrome, and it's gone by different names and whatnot over time, but you can have idiopathic, but we now call it myeloid when we know more. And so myeloid hypereosinophilic syndrome, which the World Health Organization, which is what the hematologists and pathologists go by, will call it myeloid neoplasm with eosinophilia and tyrosine kinase gene fusion. So imatinib was used for that disorder, and it was first studied by actually allergists. Butterfield was one of the authors at Mayo Clinic, looking at, I think, 3 patients with idiopathic hypereosinophilic syndrome and showing that there was an effect, a very good effect when you give that drug. And actually, as Tracy mentioned, that diagnosis actually is top of the mind if the KIT mutation is not present. And so the difference between that disorder and this one is that myeloid hypereosinophilic syndrome is much more rare than SM even. It's probably closer to 1 in a million prevalence. And so allergists occasionally will get their feet wet if they're the 1 in a million encounter. But now I think we're starting to see allergists having a much more broad experience in the community with tyrosine kinase inhibitors, which is really cool. And I think certainly the hematologists have used imatinib in CML quite extensively. It was a blockbuster drug in CML, but I think we're now starting to see the potential effects of tyrosine kinase inhibitors in SM and the potential blockbuster role they can have in that diagnosis. And so, you see the dramatic improvement in total symptom score in patients with SM. And I can tell you from anecdotal experience, the patients are very happy when they get on these drugs. And in terms of their symptom, their quality of life, how much better they feel. The next thing I was thinking, I'm blanking out. But essentially, yeah, I think it's entering the paradigm. We're seeing remission essentially of the disease, and so there's symptomatic remission, there's pathologic remission. I think one of the really amazing headlines that's come from work that Dr. George has done with the Summit trial is 55% of patients on treatment no longer are meeting diagnostic criteria for SM, which is honestly incredible. And I think it honestly makes me think of CML and imatinib. And what, and I know Lindsay and I have talked about that, before outside of this context, but it really is a very dramatic finding. And there was a poster, this one I do know this poster. So there was a 10 SM patient poster using avapritinib, and they didn't have a 6-month time point, or I should say 24-week time point, but they had a 1-year time point where they looked at bone marrows in patients at 10 years, and 4 out of 10 no longer met WHO criteria. So we're seeing, slightly different results, but different sample size and things like that, but very promising results overall, I think.
I think it's amazing that you're getting more experience with TKIs, and I am becoming a pro at antihistamines and anti-mediator therapies, which I never expected, so there you go.
That's right. I think that it's actually now is the time for allergists to really get their hands wet with TKIs, and I think it's exciting. I think your patients will love you, and patients, please go to your allergist and say, I heard this. I heard that TKIs might be an option, because hopefully I'm speaking for the team here, but these drugs do seem to make a very important difference in patients' lives. So
I don't know if I'd recommend that you send people to me for their anti-mediator therapy, but that's okay. That's all right.
Let's take one question from the remote audience. Is it right to classify SM as a myeloproliferative neoplasm?
So that's a great question. We used to classify SM as a myeloproliferative neoplasm, but in the last few editions of the WHO classification of hematopoietic neoplasms, SM has had its own chapter. And it's because it's such a heterogeneous disease. It's very different in children versus adults. You have this non-advanced and this advanced form. So there were very strong arguments made to the WHO that it needed to be its own separate entity outside of the myeloproliferative neoplasms.
All right. And then some insights with regard to dosing of these agents. Who wants to go first?
That's you.
That's me. Well, so I think this is an important question that has come up, and I think we're starting to get to this question within the context of PIONEER. So let's talk about PIONEER and avapritinib dosing. So the standard labeled dosing is 25 milligrams once a day with ISM. I think there's now a question as to whether or not that is the appropriate dose or whether or not we need to go to a higher dose, and I think we're starting to look at that within the context of PIONEER. So there is a subset of patients within the Part 3 open label extension of that study who were dose escalated to 50 milligrams a day. And I think what we're seeing based on preliminary data output is that the safety profile does seem to be similar between those 2 different doses of therapy, and again, with improved efficacy at the higher dose. And so I think that's definitely a phenomenal question. I think we're starting to get to that answer. I don't know that we have quite enough data yet, but we'll look forward to seeing that. But I do think that's going to be a discussion point for sure.
Wonderful. And what are your opinions on the safety profiles of these agents?
You're looking at me again. I'll take it. All right, everybody's looking at me. I think the reality is, I think we've seen the data, right? So I like facts and figures, which is what I tell my kids all the time. So I think facts and figures. I think you see that they're both safe, right? So they definitely have different profiles, which makes sense. They have different off-target effects. So I think we do see more edema with avapritinib. I think there is that incidence of cognitive side effects that we see with indolent disease. I will say there's obviously the concern for bleeding and the intracranial bleeding. We've seen that within advanced SM. We haven't seen that within the indolent space, but there's a certain profile with avapritinib. I think with bezuclastinib, we've seen a different profile. So we've, again, seen more hair lightening and hair color changes. And I think what this speaks to is the importance of really discussing the side effect profiles with patients because, as Bree said in her discussion, success and I think what people tolerate is per patient. And so what one patient might find is particularly bothersome, so perhaps memory troubles or that particular risk, they may not find the risk of hair whitening to be bothersome. And so I think that's where the discussion really comes in with the patients.
And you said it eloquently that success is at the patient level, and that's setting up the expectations before you even start the therapy.
And I don't think we understand why some patients have side effects and other patients have, different side effects.
But again, I think phenomenally, and this is something that has been humbling, is now we're going to have hopefully options, right?
Yes.
Which we have not had before. So I think that is the real excitement in the field in general, is the options for patients.
Wonderful. Well, this brings us to the conclusion of the broadcast. Thank you for joining us tonight, and I hope you all had fun, and wanted to thank the co-moderators or our panel here. Don't forget to enter that QR code, reviews, etc., and join us for hopefully another episode. Thank you.
Thank you, Rafi.
Yeah.
Thank you.
Thanks.